Starting with some simple definitions. Urinary tract infections, or UTIs, describe an inflammatory response of the urothelium at any point along the urinary tract, typically as a result of the presence of a bacterial infection. Cystitis is when inflammation and infection is located within the bladder, whereas acute pyelonephritis is an acute inflammation of the kidney and involves bacterial infection of the renal parenchyma. Acute pyelonephritis can be a very serious condition and has the potential to put the kidney at risk, and in the most severe cases can also be life-threatening. The presence of bacteria in the urine is referred to as bacteriuria, and it may be either asymptomatic or symptomatic. Bacteriuria is found in about 4% of young females. However, it's far more common in elderly women, in whom it has an incidence of about 20 to 30%. In men, bacteriuria is far less common. However, in the elderly male population, the incidence is approximately 10%, and this is typically related to the presence of prostatic disease. Moving on with our definitions. Pyuria is the presence of white cells in the urine, and it occurs as a result of the inflammatory response of the urothelium due to the presence of bacterial infection. We can further describe urinary tract infections as being either uncomplicated or complicated. In uncomplicated cases, this is the presence of an infection within a structurally normal urinary tract, whereas in complicated cases, there's an underlying abnormality in the structure or function of the urinary tract. For example, in a patient who has a urinary tract stone. And these underlying abnormalities have the potential to increase the complexity and severity of the underlying infection. Moving on to pathophysiology. When we look at urinary tract infections and pyelonephritis, there are three primary routes of infection. They can be ascending, hematogenous, for example, in a patient who has infective endocarditis, and they can also be lymphatic. By far and away, the most common route for infection is through the ascending route. So let's take a closer look at this. With an ascending infection, bacteria move from the lower end of the urinary tract, so the urethra and bladder, superiorly to affect the kidneys. In young females, this typically occurs in the presence of a normal urinary tract. However, in the older male patient group, this ascending infection is most commonly associated with the underlying impairment of the drainage of urine. Regarding some potential causes of impairment of urinary tract outflow, these include a physical obstruction of the tract, reflux of urine, and pregnancy. To understand how impairment of the urinary tract drainage can increase the risk of infection, we can use a very simple analogy of a stream flowing with water. Now, if you picture a fast-flowing stream, the constant movement of water means that there's no risk of any pooling or stagnation. And as a result, the water within the fast-flowing stream remains crystal clear and does not get dirty or infected. However, when we introduce an obstruction or some other cause that may potentially impair the drainage or flow of the stream, this can result in pooling of water. This pooled water can then become stagnant and infection is able to take over. So it's the same principle as that which can lead to ascending infections. However, having an obstruction of the urinary tract can actually complicate things even further, as the blockage also can result in increased pressure within the renal collecting system, which, as well as potentially reducing the blood supply to the kidneys, also increases the risk that bacteria can be pushed back into the blood or lymph vessels, and thus causing the patient to become systemically unwell. Additionally, as the blockage of the urinary tract will also affect the function of the kidney, this can make it even harder to treat the infection with antibiotics, as these would normally rely on excretion into the urine to target and be effective against the bacterial infection. The most common bacteria that can lead to urinary tract infections and pyelonephritis is E. coli. E. coli is a gram-negative anaerobic bacteria that is typically found within the lower intestines. In terms of their general features, E. coli are rod-shaped, and some strains have flagella, which are tail-like projections which allow them to move around. And also, importantly, the body of E. coli are surrounded by pili. These pili aid the attachment of the bacteria to the urothelium, and as a result, increase the ability of E. coli to infiltrate these cells and subsequently cause infection. As well as this adhesion mechanism, other factors which can increase the virulence of bacteria include the ability to avoid host defenses, resistance to antimicrobials or antibiotics, and also a diminished host response. For example, if the patient has an immunodeficiency disease. Looking at the incidence of acute pyelonephritis in the US population, the condition is far more common in females, with the incidence of 15 cases per 10,000 people, compared to only 4 cases per 10,000 in the male population. The size of the problem caused by acute pyelonephritis is indicated by the scale of the cost of treatment in the US alone, of more than $2 billion per year. In males, there is typically a bimodal peak of incidence, with the first peak occurring between the years of 0 and 4 years old, and the second peak occurring between 35 and 85. This second peak is typically related to the presence of prostatic disease, for example, benign prostatic hyperplasia or prostate cancer, which we understand can lead to impairment of the urinary tract outflow and thus can increase the chance of infection occurring. In the vast majority of cases of pyelonephritis, the patient may complain of cystitis-type symptoms for a few days before they then go on to develop pain within their loin. And this occurs as the infection spreads superiorly up the urinary tract. Most commonly, the pain is experienced in only one flank. However, very rarely, pyelonephritis may affect both kidneys simultaneously, but this is highly unlikely. In keeping with the presence of infection, the patient will typically have a fever, and this, along with the presence of loin pain, is an essential criteria in establishing the diagnosis of acute pyelonephritis. Nausea and vomiting are other important symptoms that patients of acute pyelonephritis may develop. It's important to be aware that in certain patient groups, particularly elderly patients, their presentation may be very subtle, and often they may present with acute confusion without any of the previously mentioned signs or symptoms. Therefore, we should be suspicious of the presence of a urinary tract infection or acute pyelonephritis in any elderly patient who has an acute confusional state. The differential diagnosis for acute pyelonephritis is pretty varied. This is a reflection of the fact that the infection can affect either the right or the left kidney, or in some cases, it can affect both. The key differentials include basal pneumonia, acute cholecystitis, acute pancreatitis, and acute diverticulitis. Acute appendicitis should always be considered as a differential diagnosis in any patient who has acute abdominal pain. And also, it's really important that in female patients of childbearing age, we always consider the potential for an ectopic pregnancy as a cause of the patient's acute abdominal pain. However, it would be unlikely that the patient would also present with a fever. But it's vital to make sure that a pregnancy status is carried out on these patients during their initial admission. In terms of investigating patients with presumed acute pyelonephritis, when in the outpatient or clinic setting, if our patient presents with a clear history of physical findings that are highly suggestive of acute pyelonephritis, and they are clinically well, then typically we can limit our investigations to urinalysis. When analysing the patient's urine, the most simple investigation is urine dipstick. The two key things that we look for on a urine dipstick are the presence of leukocyte esterase and the presence of nitrites. Leukocyte esterase is a type of enzyme that's produced by leukocytes, and therefore it typically identifies the presence of white blood cells within the urine as a response to the presence of infection. Leukocyte esterase is a pretty good test and has a sensitivity for identifying urinary tract infections of between 75 and 95%. However, it's important to note that not all patients with urinary tract infections will have a significant pyuria, and therefore the leukocyte esterase result of the urine dipstick may potentially be negative. Now moving on to nitrite. Nitrites are not normally found in the urine. However, they are found when gram-negative bacteria such as E. coli within the urine convert nitrates into nitrites. A positive result for nitrites on urinalysis has a high specificity for the presence of a urinary tract infection of more than 90%. However, the sensitivity of the test is much lower. Therefore, it's more accurate at excluding the presence of urinary tract infection than positively confirming it. The other urine investigation that we should undertake in the outpatient setting is microscopy, culture and sensitivity, or MC and S. This is essentially when we send off the urine sample to be analysed under the microscope to look for the presence of a microorganism, and then to be cultured, and antimicrobial sensitivities of any microorganism that is grown can then be revealed. MC and S is especially important, as not only does it allow us to confirm the presence of a bacterial infection in the urine, but it also allows us to identify the specific antibiotic sensitivities of that particular microorganism. So we can therefore better tailor our treatment for that particular infection. In patients who require inpatient admission and investigation, as well as undertaking urinalysis, we should also be performing blood tests and potentially some imaging. The blood tests that we should perform include full blood count, so FBC or CBC, which we'd expect to show a raised white cell count in keeping with the presence of infection. We should also be checking the patient's renal function, and we'd expect to see a rise in their urea and creatinine, either as a result of dehydration and sepsis, or potentially as a result of obstruction and back pressure within the urinary tract. CRP, which is an inflammatory marker, should also be checked, and we'd expect it to be elevated in patients with UTIs and acute pyelonephritis as a result of the presence of inflammation and infection. Additional blood tests that we'd also want to undertake include liver function tests and serum amylase or lipase. This is primarily to help us exclude any liver, biliary, or pancreatic differential diagnoses. Lastly, two really important hematological investigations are blood cultures to help us identify the presence of microorganisms and guide targeted antibiotic use. And also, measuring serum lactate, which is vital in identifying patients who are more significantly unwell and may have septic shock. Imaging isn't always necessary in patients with acute pyelonephritis, as generally it's a clinical diagnosis. The main reasons we would undertake imaging in these patients is to exclude the presence of factors that may complicate the condition, such as a urinary tract stone blocking the kidney, hydronephrosis, or the formation of an abscess. The types of imaging that we may use in patients with acute pyelonephritis include ultrasound and CT scans. Looking at ultrasound first. Ultrasound is not a particularly useful investigation in diagnosing acute pyelonephritis, but it can play a role in identifying the presence of an obstructed urinary tract that may have led to the infection and also hydronephrosis. And we'll be coming back to this complication later on in this tutorial series. Moving on to CT scans. The type of CT we would normally undertake in patients with acute pyelonephritis would be a CT-KUB, so a CT scan of the kidneys, ureters, and bladder. The main reason for undertaking a CT-KUB would again be to look for any potentially complicating factors, such as urinary tract stones, hydronephrosis, or abscesses. CT-KUBs do not involve the use of radiological contrast agents, which is important, as these patients may typically have impairment of their renal function as a result of the acute infection. Therefore, we'd want to try and avoid giving patients with impaired renal function contrast to enhance the CT, as this has the potential to further damage the kidney and worsen the impairment. Whilst this lack of radiological contrast does somewhat reduce the sensitivity of CT-KUBs, it still does provide enough information to be able to identify any non-renal disease that may be causing the patient's symptoms. Once we have used our imaging to exclude the presence of a urinary tract obstruction or abscess, we are then able to continue with our medical management. But it's important that we continue to reassess the patient and their clinical progression, as any subsequent clinical deterioration would make us highly suspicious that they may have developed an abscess or other complications, and this would warrant repeat imaging. Regarding how we manage patients with acute pyelonephritis, as with any condition, the first thing we have to do is assess the patient's clinical status to determine the severity of the patient's illness and whether they are able to be managed as an outpatient or require hospital admission. Not all patients with acute pyelonephritis require inpatient admission. The main group who do not, and who can usually be managed as an outpatient, are young female patients who are not pregnant and are systemically well. For this group, if they're in pain, then we should provide them with analgesia. And then, after taking cultures of urine and potentially blood, we should then commence the patient on appropriate antibiotics. In some cases, if possible, we can give these patients a stat dose of intravenous antibiotics before sending them home to complete the course of oral medication. Patients with acute pyelonephritis who require hospital admission include patients who are systemically unwell, elderly patients, pregnant patients, patients with significant comorbidities, and also patients with complicated urinary infections. In these patients, we should be giving them analgesia, intravenous fluid resuscitation, and also, after taking blood cultures and urine cultures, giving them urgent IV antibiotics. In the most severely unwell patients, so those patients with sepsis and septic shock, it's important that we involve the critical care team for consideration of escalation of their care as soon as possible. There is one variation of the condition which is treated slightly differently. These are patients who have an infected and obstructed kidney, which is a urological emergency and requires urgent physical intervention. Infected obstructed kidneys typically occur as a result of a stone blocking the ureter, leading to stagnation and backflow of urine, and the subsequent development of a urinary tract infection and pyelonephritis. However, unlike simple pyelonephritis, the obstruction of the urinary tract results in dilatation of the renal calyces and renal pelvis, causing a condition that we refer to as hydronephrosis. Patients who have infected obstructed kidneys need to undergo urgent decompression of their infected renal system to prevent further deterioration of their clinical condition. Decompression can be undertaken through either the insertion of a nephrostomy or by endoscopic ureteric stenting. In a nephrostomy, a needle and drainage catheter is inserted via the patient's skin and under radiological guidance is passed into the obstructed, infected renal pelvis. This allows the release of the increased pressure within the kidney and also enables the drainage of the source of sepsis. As we mentioned, decompression of the system can also be performed via ureteric stenting, which allows urine to flow around the obstruction. In fact, the evidence suggests that both percutaneous nephrostomy and ureteric stenting are equally effective, and therefore the choice of which to use comes down to the surgeon's preference. However, regardless of whichever technique we use, the vital thing is that we drain the source of infection and relieve the pressure caused by the hydronephrosis as soon as possible, to help limit the damage to the kidney and also prevent any further clinical deterioration. In patients with acute pyelonephritis or infected obstructed kidneys who fail to improve despite urgent and appropriate intervention, we need to be highly suspicious of the presence of pus. This can either be in the form of a renal abscess or pus within the renal pelvis, which we refer to as pyonephrosis. Regardless of the location of the pus, it's vital that these patients undergo intervention, be it radiologically guided, endoscopic, or surgical, to release the pus and control the source of infection as soon as possible. In fact, we can remember the importance of this by recalling the old adage, "If there's pus about, let it out." To summarize what we've covered in this tutorial series on acute pyelonephritis, acute pyelonephritis is a urinary tract infection that affects the renal parenchyma. It's more common in females, however it does occur in males, particularly in the elderly population. Uncomplicated and mild cases of acute pyelonephritis can typically be managed as an outpatient. However, in more complicated cases, and in patients who are significantly unwell, they'll require inpatient admission for intravenous fluids and intravenous antibiotics. Imaging is typically needed in patients who have complicated disease, or if there's any uncertainty regarding the diagnosis. Acute deterioration or failure to improve despite intervention most commonly suggests the development of complications such as hydronephrosis or the presence of pus. And it's vital to remember that in patients who have obstructed, infected kidneys, they have a urological emergency and require urgent decompression by either a nephrostomy or ureteric stenting.